All right, let's just jump right in. Welcome, Nigerian medical and health science students, to this comprehensive Cortex Hub explainer on the anatomy of the diaphragm. Now, for those of you gearing up for your second-year physiology, anatomy, or nursing exams, you already know this is a massive lecturer favorite. Today, we're not just going to mindlessly memorize facts. We're going to build your understanding layer by layer, exactly like you'd experience in an outstanding university lecture. By the time we wrap up, you'll confidently understand the structure, the physiological mechanics, and the clinical relevance you absolutely need to crush your MCQs and viva voce examinations.
Here's our roadmap for today's session. We'll start with structure and foundational anatomy, move into neurovascular and lymphatic supply, cover the major diaphragmatic apertures, apply it all with actions and clinical integration, and finally, finish up with an end-of-lesson exam review.
Okay, Part 1. Structure and foundational anatomy.
So before we can even begin to tackle complex breathing mechanics or referred pain, we need to clearly define what this structure is and how it sits inside the human body. We always have to start by defining our terms, right? The diaphragm is essentially a biological wall. Think of it as the VIP bouncer standing directly between your chest and your abdomen. It's a double-domed, musculotendinous partition that firmly separates your thoracic cavity above from your abdominal cavity below. If you picture it in your mind, it's convex superiorly, meaning it bulges up into the chest, and concave inferiorly, cupping the abdominal organs. Physiologically, this is your chief muscle of inspiration. And here's the key. When it contracts, it descends, but only the central part moves down. The outer edges remain completely fixed to your lower ribs.
Notice that pale, sort of clover-shaped area right in the middle? That's the trifoliate central tendon. Now listen closely because this is a major area lecturers love to test you on. You must remember that this aponeurotic central tendon has absolutely no bony attachment. None. It's fixed, sure, but its superior aspect actually fuses with the inferior surface of the fibrous pericardium that surrounds your heart, not to a bone. All the surrounding muscular fibers simply converge onto this floating central anchor.
Surrounding that central anchor is the muscular portion, and we divide this into three distinct parts based on where they attach peripherally. First up, the sternal part, which is just two small slips attached to the xiphoid process. Second, the costal part. This attaches to the inner surfaces of your 7th to 12th ribs, and this is actually what forms those characteristic left and right domes. Finally, we have the lumbar part. Now pay attention here, because the lumbar part is packed with exam questions. It includes the crura and the arcuate ligaments. Notice that the right crus is noticeably larger and longer, springing from L1 all the way down to L3 or L4. The left crus, it only drops to L1, L2, or maybe L3. The lumbar part also features three very important fibrous arches. You've got the median arcuate ligament arching right over the aorta, the medial over the psoas major muscle, and the lateral over the quadratus lumborum.
Moving right along to Part 2, neurovascular and lymphatic supply. Okay, so we've got the structural framework securely in our minds. Now let's explore how this vital muscle receives its lifeblood and its electrical signals. You can clearly see exactly how nerves and blood vessels interact with the diaphragm's muscular and tendinous layers here. Notice the crura we just talked about anchoring down to the lumbar vertebrae, and look at how vital structures like the aorta and inferior vena cava manage to navigate their way right through this thick muscular barrier.
Now here is a fascinating contrast in blood supply and honestly a notorious trap for students in multiple choice questions. Because the diaphragm is a dividing wall, it actually gets fed from both sides. The superior or thoracic surface is supplied from above by the pericardio-phrenic and musculophrenic arteries, which both branch off the internal thoracic artery, as well as the superior phrenic artery coming straight from the thoracic aorta. But flip it over to the inferior abdominal surface and the supply totally shifts. Now you're relying on the inferior phrenic arteries, which come off the abdominal aorta along with the lower 5 intercostal arteries. You've got to keep these origins distinct in your mind.
Let's talk innervation. This is a massive, high-yield exam point. The motor supply, the signal that actually makes the diaphragm contract, comes solely from the right and left phrenic nerves, rising from cervical spinal segment C3, C4, and C5. Remember the old rhyme? C3, 4, and 5 keep the diaphragm alive. However, the sensory innervation is actually split. The phrenic nerve handles sensory info, like pain and proprioception, for the central part of the diaphragm. But the peripheral edges, that sensory supply comes from the lower 6 or 7 intercostal nerves and the subcostal nerves. Jot down that split because it becomes critically important when we discuss clinical presentations of referred pain in just a couple of minutes.
Let's move into Part 3,
Major diaphragmatic apertures.
We are now at the most frequently tested anatomical features of the diaphragm, the major apertures. These are the openings, or hiatuses, that allow essential structures to pass between the thorax and abdomen without getting crushed. Our first major aperture is the vena cava opening, situated highest up at the T8 vertebral level. It sits right within the central tendon, slightly to the right of the median plane. What passes through it? Well, the inferior vena cava, terminal branches of the right phrenic nerve, and a few lymph vessels. And here's a truly beautiful physiological mechanism. Because the IVC is physically attached to the margin of this tendon, when the diaphragm contracts during a deep breath, it actually pulls this opening wider. This dilates the IVC and mechanically helps pump venous blood back up to the heart. It's so elegantly efficient, literally the body's own venous vacuum pump.
Next, descending down to the T10 vertebral level, we have the esophageal hiatus. Now, unlike the caval opening, this one is located in the muscle itself, specifically the right crus. Notice how the muscular fibers of the right crust crisscross, or decussate, right around the esophagus. Why on earth does it do that? Well, it forms a physiological sphincter. When the diaphragm contracts, those fibers physically constrict the esophagus, which stops stomach acid from refluxing back up into your chest. Along with the esophagus, this opening also transmits the anterior and posterior vagal trunks and the lower esophageal vessels.
Finally, down at the T12 level, we find the aortic hiatus. So the absolute crucial point to understand here is that the aorta does not actually pierce the muscle of the diaphragm. Instead, it passes securely behind the median arcuate ligament, right between the crura. Why is this structurally brilliant? Well, think about it. It means that when you take a deep breath and your diaphragm contracts violently, it doesn't pinch your aorta closed. Your aortic blood flow to your lower body remains completely uninterrupted. This hiatus also transmits the thoracic duct and, quite often, the azygos vein.
I highly recommend you just take a mental picture of this table or actually screenshot it. You absolutely must memorize these three levels: cava at T8, esophageal at T10, and aortic at T12, along with the specific structures each one transmits. If you're sitting for any health science anatomy exam, I can almost guarantee you're going to see a multiple choice question drawn directly from this information.
Part 4. Actions and clinical integration. Anatomy only truly matters when we can apply it to living, breathing patients in the hospital wards, right? So let's see how all this builds into physiological actions and clinical reasoning. Let's walk step by step through the mechanics of inspiration. When the phrenic nerve fires, the diaphragm contracts. Those domes we talked about are pulled inferiorly, flattening out that resting convexity. Because the peripheral edges stay firmly attached to your ribs, the central tendon descends, pushing all your abdominal viscera down. This simple mechanical movement dramatically increases the vertical volume of your thoracic cavity. And according to Boyle's law, as volume increases, intrathoracic pressure decreases, creating a vacuum that literally draws air into the lungs.
And this explains a fascinating clinical observation. When you walk onto a respiratory ward, you'll often see breathless patients suffering from dyspnea, sitting strictly upright in bed, completely refusing to lie flat. Why? Because in a supine lying-down position, the abdominal organs push the diaphragm up to its highest level, making it much harder to breathe. By sitting upright, the diaphragm naturally falls to its lowest resting level. The patient is literally using gravity to pull their abdominal organs down, giving the diaphragm maximum room to contract and expand their lung volume.
Okay, now let's tackle a classic viva voce question: referred pain pathways. Remember that split innervation we mapped out earlier? This is exactly where it pays off. If a patient gets an infection, like a subphrenic abscess that irritates the central part of the diaphragm, that pain signal travels up the phrenic nerve to spinal segment C3, C4, and C5. The brain gets a bit confused and refers that pain to the skin of the shoulder tip, because that skin is supplied by the supraclavicular nerves from those exact same C3 and C4 segments. However, if the peripheral edge of the diaphragm is irritated, the pain travels via the intercostal nerves and refers to the skin over the inferior angle of the scapula. Connecting the raw nerve supply to the actual clinical presentation is exactly what separates an average student from a top-tier one.
Finally, Part 5, our end-of-lesson exam review.
To finish out our masterclass today, let's consolidate everything we've covered into a rapid, one-minute revision focusing strictly on lecturer favorites and absolute must-know intel for your exams. Lock these 5 facts into your brain right now. You can forget what you had for breakfast, but do not forget these. 1. The central tendon has no bony attachments. 2. The aperture levels are caval at T8, esophageal at T10, and aortic at T12. 3.
C345 keeps the diaphragm alive. The phrenic nerve is your sole motor supply. 4. The right crus is longer and larger than the left crus. And 5. The inferior esophageal veins at that T10 hiatus form a crucial anastomosis between the portal and systemic venous systems. In portal hypertension, these veins can swell into varices and rupture, which directly links this anatomical hiatus to a severe clinical presentation like hematemesis, which is vomiting blood.
I'm going to leave you with this highly testable clinical scenario to think about before your next tutorial or exam. If a patient's right phrenic nerve is severed in the neck, how exactly does the mechanics of that right hemidiaphragm fail? And what bizarre paradoxical movement would a radiologist actually see on an X-ray? Taking the time to understand the specific mechanics of a paralyzed hemidiaphragm will prove you've truly mastered this topic. Keep reviewing, keep connecting the structure to the function, and best of luck with your studies.